Can I start? Hi, good morning, everyone. I don't think that I can present first as the second person. Yes, I am Dr. Tolly, and it's my great honor to be here amongst all of you in order to present one of the main topics of our research team. First of all, I would like to say thank you, Dr. Ron Wassman and co-chairman of the CRT conference and all organizer staff, and Dr. Thạch Nguyễn. He the head of my team, my team, and two of the presenters in here. So I hope that the conference will be successful, and congratulations CLT 25th anniversary. So the topic that I will present today is functional restoration of laminar flow, prevented late instant stenosis better than anatomical coronary cosmetic reconstruction, and angiography, artificial intelligence, and machine learning analysis. So about the background, so after BCI improved FFR, so guarantee minimal future instant stenosis. And FFR is a measure of pressure difference of coronary artery stenosis to determine if the stenosis physiology is significant. So before BCI, an FFR is a measure of BD over BA. The picture is shown here, but the abnormal FFR is reverse this ratio. So the BA is calculated by BA over BD, and this is the lower proximal pressure and higher pressure distal to the lesion. After PCI, the improvement to the FFR depends on the lower pressure distal to the stent. In our research laboratory, so we use hydraulic principle to explain the mechanism of atherosclerosis and intervention in coronary arteries. So the question is to discover what type of coronary flows after BCI and could prevent late instant stenosis, and how the speed of coronary flow distal to the stent and could reverse the FFR ratio. So about the method. So we recruited 30 patients with PCI in the mixed segment of coronary arteries, and all patients underwent a new dynamic coronary angiogram. So talk about new angiography techniques. So at first, the contrast seen at black when adjusted until the index coronary artery were filled completely, and all the images of the whole vessel were included inside the screen. Recorded the flow at 15 frames per second, so it means that 0.06 seconds for each frame, and the flow characteristic, direction, border, and the shape of the tip could be observed. So the features of coronary flow before and after BCI was identified: laminar versus turbulent flow, duration of the turbulent flow, anterograde versus retrograde flow, and the speed of coronary flow distal to the stent. So we use artificial intelligence program with deep learning algorithm programmed by Python language to search the same features. And in our research, so we use two packages, units and denseness to 121 and convolution neural network to develop two models. So model 1 will cause segmentation model, and the aim is to detect the coronary ostium. It based on the identification of the ending point of the catheter guide. The model 2 was called the binary image classification model, so which will be able to detect the start of the blood flow on the background of the contrast. The aim of this model is to detect the blood comes in the osteum, the coronary osteum. So this is the F1. This is the first round of the coronary angiogram. Finally, the model 3 will build to reduce the end of the coronary flow. So detecting the ending of segmentation of the full angiogram video, and then the first black image in each series of the segmented images. So this is the ending of the arterial phase, like this. So after that, this is the F2. So in the end of the arterial phase, we will calculate by formulas the minus F2 and F1, and then the total divided frame per second. So the ratio of the speed before and after PCI were recorded, so FFR could be calculated. And the patients were followed up for target lesion revascularization and in-stent restenosis within 2 years. About the results, so before PCI, so 87% lesions saw the turbulent flows due to the collision of the anterograde flows and against the retrograde flow. The duration of the turbulent flow lasted from 0.12 to 0.24 seconds. And after PCI, so the flow changed from turbulent to laminar flow in 85% at the newly stented segment. And the speed of flow restore to the stent and go faster and less than 0.12 seconds, and the P is significant. And we will follow all the patients with faster speed post PCI, and we show that the target lesion revascularization of 2% and the in-stent restenosis of 4%. But in contrast, the patient without restoration of laminar flow and with low speed had the target lesion revascularization of 80% and earlier in-stent restenosis. So the conclusion is that after PCI, if the flow were laminar and the distal speed were higher and the later future rate of target lesion revascularization and in-stent restenosis were minimal, and based on the results and functional restoration of laminar flow, and the speed is better than anatomical cosmetic coronary intervention, and larger studies still need to confirm the above results. Thank you so much.
Thank you for that great presentation. A question I had, and I've dabbled in this, I'm certainly not smart enough to understand all of machine learning, but you know, when we were trying to derive something similar, one of the limitations was getting enough angiograms which were of sufficient quality to derive the models from. So can you talk a little bit about sort of how many angiograms you used, whether they were from a single center or multiple centers, because that introduces certain challenges.
Yes, thank you so much for your questions. Because that this is it means that we have an engineer. We have many engineers, so they will start. They will buy CPU in the Google company, and then after that they established a build a computer machine, even that many computer. So they set up a system that's to and they code a program, and they sometimes that they can take up the packages and then they fix and then they change the code and to make them for suitable for what we want to do. So I mean that we need to do a lot, but this is it means that this is the separate of our engineer. That they can do it, and our team so have many facilities. So we work together, and then we connect the idea, and then we yes.
Maybe I'll just clarify my question. So, how many angiograms did you use to derive the model from, and where did the angiograms come from? Was it a single center or multiple centers?
Yes, this is the multiple center.
How many angiograms do you know?
About angiogram. So I'm not sure about that. I'm so sorry because that uh, mm, we just work together and then we collect the result and then I'm so sorry.
That's okay. That's fine.
I fully agree with you because when I see this type of analysis, what I get is that they are doing very quickly what we can do manually in the old times QCA analysis. I mean, this is new, but new in some way. I think the important concept is the automatization because you know I work in a core lab for years and doing segmentation of animals is very demanding, it's very time-consuming, it's very expensive. So it's something I think is important. One thing I learned, I believe your question is in that line, is that okay, we have this idea of making this process automatic by machine learning, and we get funding, we go to a company, they dedicated to do that type of analysis, and then we found that they do not analyze data as we do, because we are interventional cardiologists, and we are used to say if we are analyzing 4,000 angles, we're saying, wow, this is a giga trial. But these AI guys, they say 4,000 angles. No, we need 400,000 angles. And this is something very, very, I think that this question is important, and it's important, you know, that engineers and physicians, they can catch up together to have common ideas and put at the same level, because sometimes we are thinking about different things, and that's why I think my colleague made the question. I have to also say that what you are observing has been already described. There are a lot of models of shear stress that are derived from OCT and primary OCT. We have seen this like 5-7 years ago with the Absorb device. There was a lot of analysis on shear stress because of the higher thrombosis risk with this device. This device has a bigger struts than usual DES, so the abnormality of the shear stress was even higher. So it was easy to run the model. The findings were magnified, I would say. So this is a concept that has been already, I would say, described. I would not say proof, but described. That when you have an abnormal shear stress, at the end is an abnormal turbulence within the vessel flow. You have higher risk of neurothrombosis, you have higher risk of stent thrombosis. So what I believe is important, and I think you have to work on making the point more clear in the presentation, is that this is outcome. You know, for us this is important, you know, because for us this could take months of analysis. For AI machines, they could take hours. It's a big improvement. And I don't know if anything the audience have, anyone in the audience already have a question, comment. We lost two speakers, so we have plenty of time for discussion.
Yeah, I think that's a really important point, and I think that's one of the potential strengths of your future manuscript, is really emphasizing how you can automate a process that interventional cardiologists are already sort of doing in our heads, but we're not doing it very well. We think we're doing it well, but there's a mismatch between our confidence and reality. And so if you can make that process more consistent and feedback to the operators in real time, that's really the holy grail, right? That's what a lot of people that are working in this space are going for. And the point that I brought up before is meant to highlight exactly what my colleague said, which is the machine learning models rely on how much data you feed the model. And so the more data you can feed the model, the better it will be. And that's one of the challenges in the coronary angiography space, is like, you need a lot of angiograms, and most centers don't have a lot of angiograms to build the models off of. And then you introduce other sort of elements, which is like different operators use different angles. Like my first shot of the right coronary may use a different angle than his first shot of the right coronary. And so then the model gets confused because they're seeing sort of things in a different way. And then of course you introduce also, variation in individuals' coronary anatomy. Everyone's right coronary doesn't look the same. So, but I think there's a lot of potential in this project and certainly very interesting. And so congratulations on that.
Thank you so much. I got correcting my yes, you're right. This topic and this means what our team are following. So it means that it's really potential, and I hope that we can do the best, and then we can get in the plastic like systematic what you said. I hope that our team can do it and bring more benefit to the cardiology field.
I mean, to end that discussion, it was amazing yesterday in the main arena. They present a late-breaking clinical trial from a company from Israel. They're making the discovery AutoCAD technique or technology, I would say. And then you shot the left coronary system, and Professor Garcia said, you are doing the right when the machine already are telling you there are significant lesions on the left. So for me, that's amazing. I mean, for busy labs, this is something that people probably don't get from the process. When you are working and you have a really busy lab, a lab that do 25, 30 cases a day, all this stuff really make a difference because you can advance quickly, the turnover of the lab is higher, and you can produce more. You can serve better to the disease people. So with this comment, I think we should move on for the second discussion. Many thanks, Dr. Lee.
Thank you so much.
And I think the last speaker was also the first one. Is Dr.